Hello, good afternoon. Welcome to the Berkshire International Club's educational event. We are honored to have Dr. Neil Berman here today, who is a member of our club. Dr. Berman was born and received his medical education in Johannesburg, South Africa. He moved to the U.S. in 1979 and completed his residency and fellowship in Boston. Uh, Dr. Berman is a board-certified physician in cardiovascular disease and internal medicine. He has been a clinical cardiologist for 40 years, practicing in the greater Boston area. He was the attending physician at Quincy Hospital, Boston University Medical Center, St. Elizabeth Hospital, and South Shore Medical Center. Dr. Berman also served as the Chief Medical Officer at Quincy Medical Center, as well as CFO of Granite Medical Group and board member of Atrius Health. Dr. Berman's presentation today will focus on abnormalities of the heart rhythm, primarily atrial fibrillation, the most common rhythmic abnormalities of the heart. And after his presentation, Dr. Berman is available for Q&A, so please kindly reserve your questions till the end. Here's Dr. Berman to share his professional medical expertise and knowledge with us. Thank you.
Okay. Thank you, Virginia. So I'm going to go through some aspects of the heart rhythm. If you don't understand something that I've said or it's not clear, please interrupt me. But if you have any questions about discussing topics further, we'll have time for that afterwards. Okay, so I'm going to concentrate on abnormalities of the heart rhythm. When I was at medical school, when I was a medical student, after a few years, it was important to decide on what area to concentrate on. And every system of the body that I did, I found more exciting than the last one. There was cardiology and endocrinology and neurology and all the parts of the body. And I had to decide which one to concentrate on. And in the end, I decided on cardiology. And the reason was this, that I figured that cardiology is the simplest of all the systems of the body. It's just a pump and some pipes, and that's it. So if I could get to know that, my ability to treat people and to understand what was going on would be much greater. And so I went into cardiology. So it turned out it wasn't as simple as I thought it was going to be. But I did find it very exciting, and I'm hoping that I'll be able to share some of that excitement with you today. So I'm just going to stand here. So this is a graphic of the heart. There we go. What this is the pumping action of the heart that you can see. And these chambers here, these are the ventricles, the right ventricle and the left ventricle. And this is where all the pumping is done. The blood comes in through that valve, goes out through that valve. It goes from the right side of the heart to the lungs over here, comes back from the lungs into the left atrium, the left ventricle, and then out to the body. The actual muscle of the heart, this is where most of the muscle is, the left ventricle. That's the part that pumps blood to the body. These two things here, that one and that one there, those are the two atria, the left atrium and the right atrium. They're not so important with pumping, but what they do is they funnel blood into their respective ventricles. But what they're very important for is setting the rhythm of the heart, which is what we're going to talk about. The other aspect of the heart is the blood supply. The interesting thing about the heart is that it's the one muscle of the body that never rests. It never rests. So the heart starts beating when you're born, and it stops beating when you die, and it never stops. So it has to be it has to have a very good blood supply because it never rests. And that depends on blood vessels which run along the surface of the heart. And Those are the blood vessels that get blocked when people have heart attacks and get bypassed when people have bypass operations. But what I want to do today is to concentrate on the electrical system of the heart. What allows the heart to beat in this rhythmic fashion and what interferes with that rhythm. So I'm not going to discuss these first two things. I'm going to discuss this part here. This is a graphic of the same diagram that you saw, but it's just a simplified drawing. And I want to show you, to bring your attention to these fibers here. This is the conducting system of the heart. These you can think of as electrical wires. They work exactly the same as a wire that goes to your lamp. A current travels along it, and something happens at the end. In this case of the heart, what happens at the end of the wire is that the muscle contracts. The signal goes down the nerve, causes the heart to contract. Where's this? The signal starts here in the SA node, or the sinoatrial node, and then there's another node here, the atrioventricular node, that I want you to remember. That's an important node. These nodes are like gates. Think of them as gates. The impulse comes to the node and it gets interrupted at the gate, and then most of the impulses are let through, but the gate has the ability to stop some of those impulses if it needs to. And then once the impulse, normally what happens is the impulse travels along the atrium there, and then the atrium contracts, sends blood to the ventricle. It gets delayed here for about 1/5 of a second, and then it comes down here and the ventricle contracts. So what you get is atrium ventricle, dum dum, dum dum, dum dum, like that. So besides these nerves, there's also other influences. Other things affect the heart rate. I'm sure you can guess some of the things that affect the heart rate. Emotion. If you get excited, your heart rate goes fast, and that's due to other nerves which come down from the brain and influence and affect the sinoatrial node there. There's two systems of nerves. It's like a yin and a yang. There's the nerves that slow the heart and nerves that speed the heart up. And depending on the balance of these two nerve supplies, that's what your heart rate is. So if you're very excited, your heart will beat very fast. Sometimes with stress, it can cause your heart to slow very much. Have any of you ever heard of a vagal episode, where you have a fainting episode? And that's because these nerves that slow the heart overact and the heart slows too much. So besides those two nerves, there's also other things that affect the heart. Drugs, for example, medications or other drugs, alcohol, thyroid disease. There's a whole host of other things that affect the rate. This is what this is here. This is an electrocardiogram. I'm sure you recognize this. An electrocardiogram was invented about 100 years ago. It's a very simple thing. What it measures is just the electricity flowing through the body in different directions. You remember your doctor puts wires on you, on your hands and everything, and across your chest here. And what they measure is just electricity flowing in that direction and in this direction. And what you get, can you see, let me show you here. This electrocardiogram shows a straight line there, a little blip, and a big blip. The little blip is the atrium, is the electricity going through the atrium. And then there's that pause of about 1/5 of a second, and then you get the electricity going through the ventricle. And it's a very helpful way of telling what's going on. So now I want to talk about atrial fibrillation. I'm sure there are people here who've had atrial fibrillation. It's a very common condition. It's probably the commonest thing that I dealt with as a clinical cardiologist. And what happens in atrial fibrillation, instead of getting those nice lines going through the atrium, all these nerves start discharging at the same time, and you get something like 400 beats all firing at the same time and causing a very erratic rhythm, and all hitting the AV node, that gate over here. And what that gate does is it only lets a certain number out. So it only lets about 100, somewhere between 130 and 150 beats out, which is still very fast. But if it let all 400 through, there wouldn't be any beating and the person wouldn't do too well. So in atrial fibrillation, what happens is this is the kind of discharge you get. This is just another comparison. This is the normal rhythm with a nice even current going from here to here. And here in atrial fibrillation, you're getting this very uneven multiple beats. And this is the cardiogram that you saw earlier, the little blip and the big blip. And here you can see the baseline is very irregular due to all these beats going on. And the rhythm, the ventricular beats here are fast and irregular. So I'll give you, sorry. Okay. I'm just, yeah, here we go. So what is atrial fibrillation? What does it feel like when you get it? So most people, but not everyone, is aware of a fast, irregular beat in the chest. One of my patients described it as it felt like a gerbil was running around in his chest. And that's a pretty good description. It's not painful, but it's a very uncomfortable feeling, and it's quite unusual, and you know something's going on. And people come in not because they're in pain, but because they're really worried. What's going on inside here? Something bad is going on. That's also, other people describe it as fluttering. Sometimes you get shortness of breath. Sometimes you get dizziness and lightheadedness or fatigue. But that usually occurs in people who've got some underlying heart condition, which is now being aggravated by this fast rhythm. But sometimes there's no symptoms at all. Sometimes we'll discover atrial fibrillation when the patient comes in for their routine checkup. So it doesn't always cause symptoms. I wanted to play you a song, which I'm going to do now. I found it very funny because this is a song by an Icelandic singer. It's called My Heart is Beating Like a Jungle Drum. And it's about she's in love and her heart is beating very fast. But in fact, what she's describing is atrial fibrillation. Just listen. So in fact, that's an exact description of atrial fibrillation. It's not a description of a heart in love. But I don't know if she knows that. So the question is now, why does it matter? It obviously matters because patients don't feel well in it. But besides the symptoms, there's one other thing that's really important, and that there's an increased risk of a stroke with atrial fibrillation. And that's probably the thing that doctors worry about the most, and patients too. Besides making the patient feel better, it's also to prevent that increased risk of a stroke. This is just some information on who is at risk, who gets atrial fibrillation. And it occurs mainly in older people. And the older you get, the more likely you are to get atrial fibrillation. And then there's this high blood pressure, heart disease, diabetes. It's all the usual culprits that cause heart disease that you know about. The one that's interesting is sleep apnea. Sleep apnea is a condition where people stop breathing while they're asleep. It's quite common. I'm sure you know people. If you go to the airport and you look at the TSA line, you'll see people are carrying something. It's the mask that they need to wear when they sleep because they take it with them. So sleep apnea is very often associated with atrial fibrillation. If I see a patient who's been diagnosed with atrial fibrillation and is otherwise well, there's a 50% chance they're going to have sleep apnea, and that's the cause of it.
So the other way around.
Say again?
Sleep apnea, are you more likely to have?
No, not. I think the number of people who have sleep apnea, there is a big overlap, but it's more that people who have atrial fibrillation often have sleep apnea than the other way around. And then how do we diagnose it? Firstly, feeling the pulse. You can often feel an irregular pulse, but it's not always obvious. The electrocardiogram is diagnostic. Sometimes people have a condition called paroxysmal atrial fibrillation, which is when you have atrial fibrillation only some of the time. And it's almost never when you go to the doctor. So it's like your pet dog who doesn't do tricks when someone... So you go to the person comes in and says, I've been having palpitations and it's very uncomfortable, but it's better now. And whenever I see them, their heart is fine. But you can give patients what's called a Holter monitor. It's a monitor that you can wear for 1, 2, 3 or more days. The other thing that lately is a very good way of diagnosing is an Apple Watch. That Apple Watches are really good at this now. And in fact, I was looking at I think it's the last 2 iterations of the last 2 versions of Apple Watches. If you look at they give you a thing that tells you what's new on the Apple Watch. And almost all the new things are medical things. I guess there's nothing more about telling the time that you can invent, but there's a lot of medical applications that are now on Apple Watches, and it's pretty accurate. Okay, so then what happens if it's untreated? This is this is really the thing that we worry about most. The other things, up until I would say 5 years ago, we used to feel that if the patient was comfortable in atrial fibrillation and it was okay to leave patients in atrial fibrillation, there was no urgency to convert them back to a normal rhythm. There's been some studies lately that have come out that have shown that there is a long-term advantage. Even if the patient feels good in atrial fibrillation, if you can get them into a normal rhythm, it's worth doing. There's long-term benefits from it. So the treatment is firstly risk factor modification to try and correct those things which cause atrial fibrillation. And so that includes regular physical activity, that's 30 minutes a day, no alcohol or very little alcohol, because alcohol is associated with atrial fibrillation, smoking, sleep apnea, obesity. Again, it's all the usual culprits, right? What about caffeine? So I find caffeine always interesting. I can't tell you how many studies there have been looking at caffeine causing bad things. There's been studies looking at caffeine causing cancer, caffeine causing heart disease, and there have been studies looking at caffeine causing atrial fibrillation. So actually, it doesn't cause atrial fibrillation. So for all you coffee lovers, you can continue drinking coffee. What it does do is it might make the heart beat faster when it's in atrial fibrillation, but it doesn't cause atrial fibrillation. And now, just to get to a little information on the specific treatment. So under number 1 there, the first thing to do is to control the heart rate. When a patient first comes in, they feel very uncomfortable. You want to slow the heart rate. If you can just slow the heart rate, people usually feel better. And you can use medications to do that. Medications like beta blockers, metoprolol, those are commonly used for high blood pressure and for many other reasons. And often that's enough to make the patient feel better and they can go home. Sometimes, especially in people who have underlying heart disease, the medication doesn't work or they can't tolerate the medication. You can then do a cardioversion. What a cardioversion is, it's like, when on TV they say they take those paddles and they shock the patient. That's what it is, except it's not done like on TV. It's not as dramatic with people screaming and shouting. You've got time to do it in an orderly way. You can give the patient a light anesthetic so that they're sleeping, and you apply the paddles, and it works most of the time. It's quite dramatic. The thing that's really great about it is that there's no drug on board, so there's no side effects. Once it's done its work, the patient wakes up a few minutes later and they're fine. Then number 2 here, so what happens now? A patient came in atrial fibrillation, didn't feel well. You've got them, either they're back in normal rhythm or their heart rate is controlled. What do? So there's a whole bunch of medications that you can do which will control the rhythm. They're called antiarrhythmic medications, which work well, but they do have side effects. And the problem with taking a medication is that sometimes the patient forgets the medication, or they may have some gastroenteritis or something and they don't absorb the medication that day. So it's not perfect because there's those problems that can occur. There's a procedure called an ablation, which I'm going to come back to, which is really helpful at curing atrial fibrillation or taking it away. But the other thing to come back to, this is the one that I said that doctors that we worry about the most. It turns out that everyone who's had atrial fibrillation, even if they're back in a normal rhythm, is at risk of a stroke. I said everyone, not everyone, but most people. There's a small group of patients, usually young patients who don't have any other heart abnormality, who are at a very low risk of a stroke. But as you get older and the more things you have like diabetes and blood pressure and heart disease, the more likely you are to have a stroke. And the stroke, the rate of having a stroke varies somewhere between, on the low end is like 1% per year, but it can go up to 14% a year. So if it's above 2%, we like to treat it. So if the chance of having a stroke are more than 2% a year, we would recommend anticoagulation. Yep.
What about the Watchman?
I'm coming to it. Give me a minute. Sure. Okay. The other thing about atrial fibrillation is that if a patient goes into atrial fibrillation and then comes out of it, the chances are very high that they'll go back into it at some point. It's not a one and done situation. If a person has one episode, sooner or later they're going to go back into it as well. So this is an illustration of the cardiac ablation. And what that is, a cardiac ablation is a procedure which is done where the cardiologist puts a catheter into the groin, into the blood vessel in the groin, and just threads it up to the heart. And that's the catheter there. And what it does is it uses radio frequency. It's like it buzzes the tissue of the atrium. And it goes around in various areas doing it. It's illustrated by that white line there. And what that does is it damages the muscle or the conducting part of the muscle, not so that it's damaged in a structural way, but it's damaged in the way that it conducts electricity, so that it doesn't conduct those bad impulses. And it's very effective. It's fairly tedious. It can take several hours to do, but it's not invasive. So it might, even if the procedure, say, takes 3 or 4 hours, the patient normally will go home that day and not have any, no healing. There's no scar.
Is that called atrial fibrillation, or is that something else?
No, the condition is atrial fibrillation.
And the procedure, I mean,
an ablation.
Just ablation.
Ablation, a cardiac ablation, right.
I heard atrial fibrillation because they had atrial fibrillation.
Right, they both the two words.
When they put catheters in like that.
Right.
Yeah, of course.
So the success rate for a cardiac ablation is about 70% with one attempt, 70% successful, and 90% with 2 attempts. And the reason that you do 2 attempts is not because the cardiologist screwed up the first time. The reason is because there are many areas that he has to go to, and sometimes it's just too many to do at one sitting. So you come back at another time to do it. Here's your answer. So then this is a Watchman device. And what this is a device which is used for people who can't tolerate anticoagulation. And what it is, it's like a little basket made up of a metal or titanium, some very fancy metal frame with a material around it, and it gets folded up and put into a catheter. And then the catheter is advanced through the heart into this area here. This is called the left atrial appendage. Now, one of the reasons why clots develop is that the left atrium is not a nice, smooth structure. It's a very irregular structure with lots of bays and nooks and crannies. And when a person develops atrial fibrillation and the atrium doesn't beat anymore, clots form in those little bays. And the biggest culprit of all is the left atrial appendage. And what this does is it gets deployed into that's the Watchman device, that device getting deployed into there and then opened up so that it's occupying the space. This device is occupying that space. It then gets detached from the catheter is withdrawn, and this is left there. And it prevents clots forming in that area. And it's very successful. It works very well. So patients who have this have almost the same result as people who are on anticoagulation. And they don't need to take anticoagulation as a result of it. They need to be on anticoagulation for a couple of months after the device is put in, but then it can be stopped after that. This device is not used that often. Most people are still on anticoagulation, but that may change in time. Part of the reason is it's quite expensive. So that's what I think that's enough about atrial fibrillation. I wanted to spend a few minutes talking about other kinds of rhythm problems, the kinds where the heart is beating too slowly. The medical word for that is bradyarrhythmias. Arrhythmias just means the rhythm is not going well, and brady means slow. So there's a whole bunch of problems, and this is that picture that you saw earlier of the conducting system. And this conducting system can fray or can degenerate at any point along it. And what happens when you get that fraying, the impulse is no longer conducted. It's almost like an electrical wire that's not working properly and your light is flickering because of it. So instead of flickering, you're getting an erratic heartbeat. And the electrocardiogram where this has happened might look something like this. You can see there's the atrium, there's the ventricle, atrium, ventricle, atrium, ventricle. And then over here, there's atrium and no ventricle. You can see that there's one missing. And what's happened there is that the conduction at the AV node has been blocked because it didn't conduct properly. And if that had to happen, or there had to be a longer pause here, the patient would faint or pass out. Yeah. So, and the treatment for that would be a pacemaker. So that's one use of a pacemaker. This is what a pacemaker looks like. The picture here, this is a woman who's had a pacemaker. It's a tiny scar. It's a very easy procedure to do. The pacemaker is this device here. That's the battery, and all the electronics are all in here. And then it's got leads at different numbers, sometimes 1, 2, or 3 leads coming out. And these leads are put into the subclavian vein, and they just pass into the heart and sit in the heart like that. At the end, I don't know if you can see this, sometimes the pacemaker lead has a tine on it, like a fishhook, like a little thing that catches in the heart muscle and just stays there. Or sometimes it'll have just a little wire, like a corkscrew wire, and then the doctor can just screw it in to the heart. When it's put in under local anesthetic. It's really a very minor procedure. It takes 30, 40 minutes to do. And so initially the first pacemakers were invented in the 1950s. And from about 1960, they've been used pretty extensively. I actually read somewhere that the first patient who had a pacemaker put in outlived the doctor who put it in. So So this is an electric catheter which will give an impulse to the heart. It replaces those conducting tissue that you saw, and the heart will beat in the normal way. This one here is in the atrium, and what it does is it senses when the atrium beats. So when the atrium beats, in other words, when the body says, I need a beat, it senses it here, and then a fifth of a second later tells the heart to beat there. So that the pacemaker actually simulates the normal situation. If the person falls in love and their heart has to beat like a jungle drum, it'll just tell it to do that. The second use, another use of a pacemaker, is for ventricular fibrillation. Now you remember we spoke about atrial fibrillation, where the atrium beats erratically, very fast. There's also a condition called ventricular fibrillation, which is much less common and much more serious. So ventricular fibrillation is what happens when a person has a heart attack and has a cardiac arrest, which you've heard of. And the EMTs have to get there within 4 minutes in order to give an electrical shock in order to restore the heart rhythm. So obviously that's a very difficult situation. People can't be within 4 minutes of an EMTs for their whole lives. So what's been developed is what are called AICDs, automatic implantable cardiac defibrillators. So what that is a stronger battery than the other one, although it looks the same, and it also has wires going into the heart. But these wires give a very strong shock if it detects the defibrillator. The ICD can detect when the ventricle goes into ventricular fibrillation, and it will automatically give a shock, and the patient will recover. So it's life-saving. These are life-saving devices. We can identify many people who are at risk of having a cardiac arrest. Anyone who has had one before will get one of these, and it can be life-saving when it works.
So they only give the shock when they sense that
exactly. So a person might have it for years before it goes off, but when they need it, it's there. You only have one chance to get it. And then the third use of a pacemaker is, if you look at this, if you look at the left ventricle, you can see that both sides, that side there and that side there, are contracting at the same time. So you're getting all the blood being squished out like that. But in some patients, the heart doesn't beat exactly at the same time. So you get the one side beating and then the other. So you get like that. So blood gets squished from side to side instead of being ejected out. And we can put pacemakers in so that you have one lead there and one lead there, and it tells the heart to beat at exactly the same time. And that can be very helpful for people with certain kinds of heart failure. So, I'm sure you're getting tired now. So just to go over what we did. We looked at the electrical structure of the heart, atrial fibrillation, some of the slowing problems of the heart and how they can be helped by pacemakers. But we didn't look at the blood supply or the pumping action of the heart. Maybe that's for another time. So I'm open to any questions if you'd like.
How do you know when someone needs a heart transplant?
Heart transplants are when everything else has failed. So most people who have a heart transplant, they have a problem with a pump, that first part. So the heart muscle is not pumping, and they've tried many other things. When the heart muscle has been damaged by several heart attacks or by a condition of the heart muscle itself, and it's not pumping, and medications are not helping, they then get put on a transplant list. I can tell you that the number of patients who actually get transplants is very, very rare. I had 2 patients in my whole career who had transplants.
Well, I know one.
Yeah.
I'm a therapist, and I have a client.
Right. But it's still, is in terms of how often do people get it, it's very rare. And part of the reason that it's rare is it's hard to get hearts it's not that there's a lack of candidates, there's a lack of donors.
Question. I read an interesting article, I can't remember where. Fortunately, I remember what it said, which is good that I remember anything. And it talked about a number of tests that were given frequently, and now there's a movement saying some of these tests do more harm than good, and they're overused. Everything from PSA to mammography to stress tests. I was interpreting for people with stress tests. They usually talked about symptoms like palpitations, shortness of breath. I don't know if they were AFib is used for that or not, but I just wondered what's the current thinking about stress tests? When are they used? Are they overused? Or what can you tell us about that?
So I'll tell you the problem with stress tests. Everyone's heard of, oh, he went to his doctor, he had a stress test, and he had a heart attack in the parking lot as he walked out. That kind of story. You've heard that. And the problem with stress tests is you have to have a question. If you do a stress test on a patient, say, let's just do a stress test, make sure everything's okay, that's a bad reason to use it, because it can give you an equivocal result that you won't know how to interpret, and it'll lead to another test, and to another test, to another test. A stress test is very good when you have a question. And what I mean by that is this, is the patient comes to me and says, I've been having this odd kind of pain, and it's like a funny pain when I go upstairs. It's not a pain, but it's this kind of symptom. I don't know what to make of it. A stress test is very helpful, because my question there is this pain due to the heart? And the stress test will answer that. But if you have an open-ended question like, let's see if everything's okay, a stress test is is not helpful at all and can be very confusing.
Is it used for people who have AFib? I know people talked about palpitations and shortness of breath when they came in for the stress test, which was, I guess, the justification for it. Is it nothing to do?
No. Sometimes you might. There's not a direct correlation between the vascular disease, the blockages in the blood vessels, and atrial fib. They're two separate things. So a stress test is not usually part of the workup for atrial fibrillation. An echo is, an echocardiogram, because you want to get a picture, you want to see what the size of the ventricles and the atrium is, and what the likelihood is of the patient going back into it. But a stress test is not part of it. A stress test answers questions about the blood vessels, about whether they're blocked or not.
You mentioned bradycardia. What about tachycardia, and what if you have both bradycardia and tachycardia episodes, sometimes within an AFib episode at the same time? How does that
Right.
go?
So sometimes that's called a sick sinus syndrome. It's an abnormality of the regulation of the heartbeat. And what happens in those people is sometimes the heart beats too fast, and sometimes it beats too slow. And then sometimes if you treat the fast heartbeat, then the slow heartbeat gets much worse. Or if you treat the slow heartbeat, the fast heartbeat, and you get stuck in that dilemma. And those patients sometimes, depending on how severe it is, but sometimes end up with a pacemaker to back up the to prevent the heart beating too slowly, and then get medications to prevent it beating too fast. But it's not usually life-threatening, but it can be very distressing, because both of them are symptomatic. Too fast, you get palpitations, and too slow, you get dizziness.
I have a resting heart rate of about 50 to 55, and I'm not a long-distance runner. And at night, my Apple Watch says that I sometimes go below 45 for 10 minutes. Any danger there?
Are you on any medication?
Thyroid and statin.
No, I think that's fine. It's not a problem as long as it doesn't bother you. So if you're not dizzy from it, it's fine. Just with the thyroid, I presume your thyroid is normal. If your thyroid is low, if your thyroid level is low, it can cause a heart rate. So you just want to be sure that that's not the case. But it's not dangerous, and yeah, I wouldn't treat that.
Follow-up question. Heart murmur.
What is that?
I heard it myself. It's a sound when the heart beats. What is that? What's
Okay, so what a heart murmur is, if you think of a faucet, of your kitchen faucet, and you start switching it on, okay, and you switch it on slowly, it doesn't make any sound. And when you reach a certain volume of water, it goes like that. That's a murmur. That's what a murmur is. So the murmur is due to the fluid going across an orifice. Now, it can be for two reasons. It can be due to the orifice being narrowed, or it can be due to the increased volume across a normal orifice. So some murmurs are functional murmurs of no significance and not anything bad, and other murmurs are due to narrowing of a valve, causing that turbulent flow. The flow across the valve is not all the time, it's only with each beat. So you hear Pregnant women often have murmurs because in pregnancy, your cardiac output is increased. So they have an increased flow across a normal valve. It's of no consequence whatsoever. It's not pathological. If it's a normal flow and the valve is narrowed, it depends how narrow, and that's when you decide what to do about it. Usually an echocardiogram is very helpful at determining that.
Speaking of women, why do women have different symptoms of heart attacks than men?
I could give you a facetious answer, but I won't. I don't know. They do, you're quite right. Why? I can't answer that. I don't know. And I don't know if anyone knows that. But definitely especially with heart attacks, women present in a much wider variation of symptoms than men do. And I think people also associate heart disease with men, so they often don't suspect it in women, so they don't interpret, they're not alerted to the symptoms in the same way as they would be with men.
We got Apple Watches because our neighbor, who was at a performance in Albany, her watch went off and said she was having a problem with her heart. She had absolutely no symptoms. They told her to go to an emergency room. She came all the way back to Great Barrington and went to Fairview Hospital. And they did a blood test, and sure enough, she was having a heart attack. But she had no symptoms whatsoever.
Huh. Yeah, that's unusual.
So we got Apple Watches because it alerted her and saved her life.
I must say, at first I thought it was overkill, but those watches are pretty clever. They do pick up a lot of stuff. So?
I'm just curious, when the picture that you had of the heart, it looked like the left side was bigger. Is there a reason? There must be a reason.
You're absolutely right. That is the case. And the reason for that, something like the two ventricles are where the muscle is. Those are the two, that's where the pumping is. You could see it on that graphic. The left side has got about 70% of the muscle and the right side about 30%. And the reason is that the left side's got to pump to the whole body. The right side only has to pump to the lungs. So the pressure on the right side of the heart is about 30 millimeters of mercury. The pressure on the left side of the heart is your blood pressure. It's 120, 130. So it has to be much stronger. Your observation is completely right, and that's the reason for it.
How does heart rhythm problems, are they typically inherited, or is there no relation between that a parent could have the problem but the children don't, or that the parent don't have the problem and the children and don't?
With atrial fibrillation? Mm-hmm. There is a hereditary aspect to it, that you do tend to see it run in families. I can't say, it's not a strong thing like if the father has it, the son will get it for sure. It's nothing like that. But you do find it in families. It may be more complicated than just genetics. So because there's certain, like people who are tend to be overweight, or not just, but just have that kind of physique, have a very big chest, are not tall and thin, but are more stocky, tend to get atrial fibrillation more. So that might be the part that's running in families. And it's not to say that the parent has it, the child will definitely have it, but it definitely is more common.
Did I hear you say correctly that if you've had AFib once and had an ablation, I've had an ablation?
No. What I said was, if you get atrial fibrillation once, then you almost certainly will get it again. An ablation is designed to correct that. So once you get, if you have an ablation, you're still more likely to get atrial fibrillation again. You're more likely than the average population, but it doesn't mean you will get it. Okay. So one of the issues that doctors wrestle with is what to do about anticoagulation if someone's had an ablation. And there's a lot of controversy about that, because if you've had say if you're 75 and you have high blood pressure and you have atrial fibrillation once, you need to be on anticoagulation. But if you've had an ablation, do you need anticoagulation? And that's harder to tell, because you by no means definitely going to get it again, but you may get it again.
We're often asked about just that family medical history as a common question. My father died, he was found dead, I guess heart, but he had severe emphysema. And I sort of been told that would weaken his heart. And that's why he didn't have any heart issues. He had high blood pressure, but nothing else. When I'm asked about my family history, does that mean that I am at any greater risk at all, given what happened to him, or he was a heavy smoker and he had emphysema, or am I completely fine as far as heart history?
Well, there's no such thing as completely fine, right?
No, I'm not completely fine.
No. So the question is, all those things add to each other. So if you're talking about what is the risk of having heart disease, having premature heart disease, say heart disease at a young age, we're not talking about 80 or 90, we're talking about 50 or 60. The chance, if you have a family history, then you definitely are at greater risk. But the other things as well, if you smoke, if you have high blood pressure, if you have diabetes, all those things will add to the risk. If you don't have those things, it makes them less likely. But where that might be useful, let's say if you came to me and we had to decide about a cholesterol medication for you, and you said that your father died of a sudden death, that might incline me to treat the cholesterol more aggressively than I would otherwise. It's that kind of thing. Not to say you would, it's all probabilities.
Those mitigating factors of his
right.
emphysema.
Well, but you see, it's there. So the question is it worth taking a medication to reduce the risk? If the risk is very low, there's no point. But if the risk is significant, you might want to. And that might push you a little bit. Other than that, it wouldn't make a difference. I'm not saying you have to. It might just be something to take to.
Cholesterol.
I heard of a pacemaker before. I never heard of a Watchman, though. Are these items things that a doctor can tell have been activated so that they know that something active is going on? In other words, that Watchman you said might be in there for quite some time until it actually used.
No, that's not the Watchman. The Watchman was the device for the clotting. The one you're talking about was the defibrillator, the AICD. Okay. That would be quite obvious because you could see it on the chest.
You could see that it's doing.
No, you can actually see it under the skin because it's implanted under the skin. It's a fairly big thing. It's bigger than a pacemaker because it has a stronger battery. But unless the patient is quite overweight, you wouldn't be able to see it. But an X-ray would show it. You'd be able to see it on an X-ray quite easily.
Because it would seem to me if that is activated, it means that something more is happening.
Well, if it's not happening, it's monitoring. So most of the time that ICD is just sitting there watching. It's just checking every beat, and every beat, it's like sees a beat, okay, sees a beat, okay, sees a beat. Then suddenly it sees a beat that it doesn't like. Then it jumps into action. But while it's monitoring, all it's doing is watching. It's not doing anything else.
From an external point of view, a physician
should know about it. Yeah.
Would you know that something has happened?
You mean if the patient gets a shock?
Well, the patient would know. Is that correct?
You would know about it, but not by looking at the patient. What I didn't tell you about, one of the great things about all these pacemakers is you have a computer, like I have a computer in my office. It's a special kind of computer with a wand, And you just put the wand on the skin like that, and it can interrogate the device. It can tell me everything that's been happening. It'll even give me an EKG of what rhythm it saw that caused it to act. So it's really amazing, yeah.
So you can find out that something.
Not only then, I can say, well, I don't like this setting. I think it was delivering too much voltage. I'm going to reduce the setting, and I just make it an adjustment on my computer, and it changes it inside. Or I can say, I want you to make the heart beat faster or slower or higher or low, whatever I want. There are about maybe 100 different parameters I can change, and can do it all through this computer. And you can even do it sometimes you can even do it when the patient's at home now.
I was curious, what is the shelf life of some of these devices after it's implanted in your body?
Yeah. So it depends on the device, but generally it's 7 to 12 years. The battery will last 7 to 12 years. And when it's specially designed so that it'll give you about 3 to 6 months of warning when the battery is going to fail. So most patients who have a pacemaker will have a little monitor next to their bed at home, and it'll just check their pacemaker while they're sleeping at night. And when it shows a signal that the battery, say, got 3 months left or 6 months left, it'll tell the doctor. The doctor will make an appointment. There's lots of time. Bring the patient in, check it again, and then make an appointment to have it done. It's a day procedure in the hospital. You come in, done under local anesthetic.
So do you remove the entire device? Or?
Not the wires, just that battery part. Yeah. The wires sometimes have to be replaced after many years, but usually after 7 years it would just be a battery replacement.
Interesting. Wow.
I'm sorry, I was just almost going to ask you the same question because I was wondering about the battery.
You need to speak a little louder.
Sorry, I was just wondering, thank you. I was about to ask a similar question because I knew somebody who had something problematic and everything, but this was a long time ago. So I'm just wondering when did what you have just described come into play? Is it very recent?
That reason that the battery lasts? You know what? It depends on the device. Like the defibrillator, if the patient needs it a lot, it drains a lot of battery when it gives a shock. The shock that the defibrillator gives is quite a shock. It's enough that the patient will go like this. They'll feel something in it, but it's better than getting the shock. It's much less voltage than they get with the paddles because it's inside the heart. It's delivering the shock right inside the heart. But if the person has many shocks, then the battery will drain quite quickly. Most people don't. Most people just have a few and it'll last for 5 years. Pacemakers, 7 to 12 years.
What is the shelf life of the battery before it goes into a person? Is that part of the 7 to 12?
So from the time...
So when it sits on the shelf for 2 years?
No. Firstly, I don't think they keep them that long. Because it's not like you have I don't know how long they keep them at the factory, but I don't think that's an issue. It's usually 7 to 12 years from the time that you're using it, from the time that you insert it. Most of these pacemakers are not more than a year old. So
you've got to figure that into the stuff.
No, not there's a lot of variables, but most of them will last. You can tell, I will tell a patient when you put it in, you've got probably at least 7 years, and sometimes they'll be much longer.
So Neil, it seems like most cardiologists deal with a whole range of arrhythmias. At one point, do people get referred to a specialty like of cardiology, like electrophysiology?
Right.
And if you're referred to an electrophysiologist, is it also important to continue working with your regular cardiologist?
Right. Okay. So most of all these insertions of these devices would be done by an electrophysiologist. That's a cardiologist who specializes in electricity. The pacemaker itself, just to follow it, to check the pacemaker, that can be done by a general cardiologist. So you wouldn't see an electrophysiologist for that. They spend a lot of their time in the lab or in the operating room putting these things in. So they don't have, you don't need to see an electrophysiologist just to monitor it. So, for example, I was a general cardiologist, so I would see patients with pacemakers and defibrillators, and then if I detect something's not right, I would send them to the electrophysiologist, who would then do whatever's necessary. It might be change the battery or put in a device. Depending, in answer to your question, should someone see an electrophysiologist and a cardiologist? It depends on what else is going on. If there's other cardiac conditions, definitely they should. But there are people who might be completely healthy, they just have atrial fibrillation. But they would generally not have to see an electrophysiologist for that.
How do they see how to thread the wire in the heart if they're not cutting you open? Is it with an X-ray?
That's an interesting question. I'm going to give you a long answer to that question, because one of the things that's been very instructive to me in life, and bringing up kids especially, comes from an answer to your question. So what you do, there's a lot of procedures where you use catheters. So what you're doing is you're standing at the groin over here, and you've got a catheter in your hand, and you can float it up, and you've got an X-ray where you can see where it is. But you want the catheter to go somewhere. And it's a bit like threading if you imagine you've got a 3-foot needle and a 3-foot thread, and you're trying to thread them. So it can be quite hard, but there's techniques and things that you learn how. To come to my lessons there, when I was a cardiology fellow, so you're learning how to do cardiac catheterizations, which are more for the vessels, but it's the same idea. You're trying to get a catheter to go down a certain area, and you can't. So what most fellows do when you're training, you think, well, I'm just stupid, or I'm inadequate, and you try and you try. And after a while you realize, if something doesn't work, try something else. That when you can poke it once, twice, 3 times, 4 times. On your 25th time, it's still not going. It's no good repeating the same thing. So try a different catheter, a different shaped catheter, or try, instead of turning it left, turn it right. But the lesson that I'm talking about, which I think is great for children, is if something's not working, try something else.
During this process, is the patient under anesthesia, or are they awake?
They usually have some sedation. Some patients like to watch it because you can watch it on a screen. So some patients will sit and watch and chat to the doctor. You don't have to be. Some people find it too nerve-wracking, so they give it some light anesthesia, just to put them in la-la land. But not. You don't need it for pain. There's no pain involved.
I've watched them done when I was working at the hospital. They were awake.
Yeah. So you watch one on someone else or on you?
Somebody else, fortunately.
Oh, no, but I've seen patients there watching themselves, which I've... Yeah, it's like an angiogram. It's less invasive than an angiogram because it's only going through the vein. An angiogram goes through the artery, which is a much thicker blood vessel. All these procedures are done through the vein.
Very helpful. Thank you. I really appreciate it. I'm sorry I can't make it.
Okay.
Thank you.
I have a younger brother who, when he was a kid, they said he had a valve that was leaky.
Right.
And all through his life, he couldn't do physical education, he wasn't drafted, and it wasn't until he was in his mid to late 40s that they finally did some surgery and replaced a valve, and they put in a pig valve. Mm-hmm. And then a number of years later, I guess that pig valve lived its life. They went to a cow valve, I think it was. Is he going to need another animal sacrifice for him? How long do these things last?
It improves all the time, so that with each iteration, they do better and they treat the valve. The kind of animal doesn't really matter. What they were using is they're just using the tissue, and there's still a lot of plastic and other materials in the valve. And I can't tell you that a pig valve is better than a cow valve, is better than a horse valve. They use all those materials. It just depends on the manufacturer. But in general, the duration that valves last for increases all the time. It improves all the time. So in answer to your question, will he need another one? I could answer that two ways. I could say, I hope not, and that his present valve is great. Or I can say, I hope he will, because he's going to live so long, he's going to need another valve.
I hope so.
I pick up bits and pieces as an interpreter. I had a patient who had a valve replaced when he was young, in his 20s, and they said because of his age, they didn't want to use an atom. They used a metal, and when they do that, then he's on Coumadin for life. But if you get an animal one, you don't need the
That's exactly right. It's exactly right.
all this information.
Yeah. No, you're exactly right. That in certain positions, the metal valve or a artificial valve without any natural substance lasts for longer. So in young people, you tend to use those. But the downside of that is you have to use anticoagulation. Anticoagulation. Because those valves can clot sometimes. And Coumadin is hard to use. The anticoagulation that's used with atrial fibrillation now is not Coumadin in most patients. They're called DOACs, direct oral anticoagulants, Eliquis, and there are a few others. And they're great because you don't have to have blood tests. You can just take the same dose every day. Pardon me? Xarelto is the same. It's just once a day, right?
I have a question, and I even hate to think about it because it's been 15 years or so. I've had cardiac catheterizations. I've had 2 cardiac ablations. I now have a pacemaker. And the interesting thing is my weight's good. My blood pressure's always been like 116 over 70 something. And then all of a sudden, after the ablations or something, I got high blood pressure. Now I have not only a cardiologist down in Springfield who takes the office and everyone takes really good care of me, and my pacemaker is monitored right next door. So they just bring me in, and I have a monitor by my bed, like you mentioned, and it tells me even what my battery's doing. The downside of having a monitor by my bed is they only will call like it's between 9 and 5 and not on weekends. If something really is bad, I have to call 911, and I live alone out in the middle of nowhere. Now they're finding, even with the pacemaker, that they sent me to see a cardiologist that deals right down in the Bay State area, that deals specifically in heart failures, because I've been getting, on my left side going up and down, there's been pains. I hate to say pains because I really tolerate a lot of pain, but I feel uncomfortable every now and then. And I'm thinking that maybe it's because of the pumping, you said that pumps most of the blood. Because now they have me on different medication, because they said that even with the pacemaker, the heart is working very, very fast. Now they also put me on Entresto, my regular cardiologist. I'm so tired of all this, I can't tell you.
Yeah.
So I think they're worried that's going to take a while. They said 6 to 9 months to see if that strengthens my heart. And the funny thing is like I take my blood pressure, I hardly take it because I figure I'm just not going to worry about it anymore after all these years.
So what's your question?
They wanted me. So my blood pressure is now 109 over 69. So my question is, the pacemaker didn't seem to do what they thought it was going to do.
No. I think the problem you're describing is not a rhythm problem. The problem you're describing is a pumping problem. Entresto is a drug that's used for pumping, to improve the pumping action.
They never mention pumping. They talk about the heart, the electricity, and the pumping, but they've never.
So clearly it's a complicated thing. So I don't want to give you incorrect information. But the one thing from what you've described is that this is not just an electrical problem. So this is a pumping problem as well.
So that's why they put me on Entresto.
Yeah.
Okay, yeah, that makes sense.
Yep,
I have a question. A number of years ago, my mother had a mitral valve failure, which is the one that, now that I got educated, which is the one that, because her lungs got flooded. So it's the one that's the smaller valve. And she had a pig replacement. But in those days, they had to crack your chest, open you up. They can't go under your arms or something else. And it's quite invasive. And then after the surgery, she had some sort of tissues that grew together. They had to open her up a second time and adjust it. What's causing that? I'm just curious. What might be causing that?
I don't know. I don't have enough information to answer that question. It sounds like a complication that not affecting the valve, but affecting the tissues around where they were operating. Yeah.
Vice President Cheney died, and I understand he had his first heart attack at 37. He eventually got a heart transplant.
That's right.
I was always wondering, did he get a transplant? It seemed to me he was a poor candidate because he had heart problems all his life. Did he get a heart transplant because he was in a position that he was in? Because you just said how difficult it was.
I think I thought this. I thought about that at the time. I must say I did, because he was very old. Because usually, because hearts are so hard to get, donors are so hard to get at. There's a lot of strict criteria. Then people give us criteria so that the best candidates get it. And he was very old to get a heart. I think he was at least 75, or maybe he was in his 80s at that time. I don't remember. But he
just died at 84.
So he was in his 70s, maybe. Yeah. But it was still, at that time, it was unusual. So you wonder if, and there's been quite a lot written now about who gets, when you look at, hospitals have policies as they're supposed to be objective, but when you look at who gets heart transplants, wealthy people get much more heart transplants than poor people do.
With modern medicine today, what are the chances that we could be building a synthetic heart? Are we close, or we are way off at this point still?
There are things called it's called an LVAD, a left ventricular assist device. It's an external pump that acts as the heart. And you can carry it around, you can go home with it. It's a scary business. Well, they were designed for people who are waiting for heart transplants. So that their heart is really given out. So they have this pump which they wear on a belt, or the pump might be inside the body, but the battery is worn outside. And there's a lot of infection problems and stroke problems. It's not worked. It's not a great alternative. If a patient gets that, I had a few patients who had that, and I never felt happy when they got it, because I knew they were in for a hard time. It's better than dying, but not much.
Yeah, because I was, you read about the fact that, the pig,
that might be.
The pig genetics are more similar to the human, so they could genetically modify, the pig, whatever, and then eventually.
I can tell you some of the things like this, like an ablation. A lot of the things that I saw at the end of my career, I never imagined at the beginning.
There's novels written about people getting heart transplants and having personality changes. Is there any truth to that?
I don't know. I haven't. No, I don't know. I didn't see that, but I can't tell you that I've seen 50 heart transplant patients to give you an answer, to give you a good answer.
It's like Bryant is a man, and he got a woman's heart. And, I wonder Is he a kinder gentleman?
Oh, are women kinder and gentler than men? Okay.
So what is the
That's different from a
new
masculine
training process for new cardiologists, given all these new modern scientific advances? Is there additional training now required?
Yeah, there is. So I think when I qualified, you needed to have 2 additional years of cardiology training, but now I think it's 5 now. Yeah.
So that's in addition to residency?
Yes.
So you're like 8 years?
So, well, my daughter is a pediatric surgeon. She had 17 years before she could practice. So if you take from the time, if you include everything, from the time she finished school until she could practice on her own, was 17 years. So it was undergraduate, medical school, residency, fellowship, all the training, yeah. And so, and cardiology is like that too now. There's after medical school, there's 3 years of internal medicine, another 7 years of cardiology, 5 or 7 years by the time you finished, yeah. Okay, well, thank you very much.